In this video, we pick up with bronchitis. Again, just as a reminder, bronchitis for me falls under the category, the umbrella of chronic obstructive pulmonary diseases. Bronchitis creates its obstruction in a different way and can occur in combination with emphysema and asthma. But for this portion of the lecture, we're discussing it in isolation, we're discussing it by itself. Bronchitis alone is diagnosed as a productive cough, that is, a cough that produces sputum, for at least 3 months in each of 2 consecutive years. So this would think of like allergy season. So in February, May, when things start to bloom, suppose someone has a chronic productive cough from all of February, March, and April, perhaps even into June, April, or into May. And that happens every year for 2 years. That would be criteria for one to diagnose bronchitis. That doesn't mean that that will be the only way that bronchitis gets diagnosed. It can be diagnosed from a biopsy, a bronchoscopy, or other diagnostic methods. But that is the classic criteria, is productive cough for 3 months of the last 2 years. The characteristics here that are unique to that are different from bronchitis, which differentiates it from asthma and emphysema, is hypertrophy of the mucus glands in the large airways. So these glands that rest in the lung, in the airways that produce mucus, they're the glands we need to help us prevent ourselves from having infection. These glands have a great function in that when we inhale something from the air that's potentially infectious, the mucus that's produced by these glands can trap that infectious source. We can then cough it up and prevent ourselves from developing pneumonia. So if those glands become hypertrophied, in other words, become large, too large, or oversized, they, one, can produce more mucus, and two, occupy space, so they can create partial obstruction. This can also produce chronic inflammatory changes in the smaller airways. So distal to the larger airways, you can get inflammation as a result of some of these changes. And as I've alluded already, excess mucus production, with both the combination of inflammation, hypertrophy of the tissues, and excess mucus production, we have a reason to cause, or a way, I should say, reason or way, doesn't matter, that can cause an airway obstruction. Patients here can experience mucus plugs. In this case, it is exactly what it sounds like. It's a portion of mucus that is very thick and actually plugs or occludes the airway. Obviously, the farther up it is, the more of a respiratory emergency it can create. So here we have a couple of images that depict the changes in cross-section as a result of bronchitis. So on the left, you have a normal bronchus, and on the right, you have chronic bronchitis bronchus. Notice that the inner lumen of the bronchus is nice and patent and wide open in image B, or on the left side. And then if you notice if you contrast the lumen in the chronic bronchitis image, you can see what we mean by increased inflammation. There's increased size of the mucus glands, there's excessive mucus secretion, and as a result, you can see how significantly the airway becomes compromised. In these two images, these are electron micrograph cross sections of the comparable tissue. So what I have, the blue box on top is normal lung tissue. That blue box from image A is the normal wall of the airway, the bronchial or bronchus here. If you notice in the bottom image, you can see where the mucoid glands have become quite enlarged. That's this portion here. I'm now moving the cursor around that. I hope you can see that. This is quite enlarged compared to the mucoid gland here, this mucoid layer here. Notice this very large emanation of mucus moving out into the air passage. You can see how that could definitely compromise the airway. Commonly, bronchitis is exacerbated by inhaled air irritants, and those irritants exacerbate a chronic condition, but similarly, irritants are what also created the chronic condition. Most commonly, as with emphysema, this is a side effect of smoking. It's a result of smoking. You can also see with that as a causative factor how easily both bronchitis and emphysema can occur together. This chronic irritation and inflammation causes an increase in the goblet cells, and as I've mentioned and demonstrated to you already, these mucus secreting glands that then produces the bronchial wall thickening, which I've shown you images of, and as a result, this condition perpetuates itself because adjacent alveoli become damaged as a result of macrophage activity. So we have a compounding of a problem. We get an irritation to a portion of the bronchus, and then that irritation creates an inflammatory response which affects the surrounding tissue, which then results in macrophages damaging and attacking surrounding tissue, which produces increased goblet cells, which produce increased mucus adduction, which produce increased inflammation. And this is a very self-perpetuating problem. As with emphysema, we're going to focus our attention primarily at first on health history, looking for history of irritants or family history. Again, as with emphysema, did someone in the house smoke? Did everyone in the house smoke? Did you smoke? Did you travel in a car often, long journeys with cigarette smoke? So secondhand cigarette smoke, was that an issue? If not, were other people in the family diagnosed with bronchitis in the past in the absence of any smoking history or any kind of inhaled irritants beyond normal? Then you start looking at other hereditary components, as we did with emphysema. Usually these patients have a chronic and productive cough, not necessarily with emphysema. So it's kind of a contrast. Now, obviously, if a patient has both emphysema and bronchitis, they could have a productive cough. But that production is commonly a result of the bronchitis. You will also see accessory muscle use. You will also hear crackles. In this case, not because of atelectasis, as we mentioned before with emphysema, but as a result of mucus rattling in the airways. So as the air passages exchange air, as air moves back and forth across those areas where mucus secretion is occurring, that can produce a crackling sound. These patients may also have hypercapnia. Commonly, if it's hypercapnia, it's because they have a component of emphysema, not always, but commonly. They may have wheezes from these narrowed air passages. As I showed you in the previous picture, this airway is definitely narrowed. A narrowed airway could cause wheezing. In that case, the airway is definitely tighter. So possibly wheezes. They may have hypoxemia. As I mentioned, and I just showed in the picture, not only is that airway tighter, it has mucus obstructing it. So they may not be getting oxygen effectively into the tissue. Whereas emphysema, they're having trouble getting CO2 out. So just a little bit of contrast there. So with bronchitis, again, treatment is going to focus on smoking cessation if that is an issue. Bronchodilators are huge here because you saw the image that depicted the diameter of the internal lumen of the airway. that definitely needs to be opened if we can open it. We want to address inflammation if we can. So, but primarily we're going to focus first on anticholinergics. They're going to help reduce secretion production, and beta agonists are going to open up that airway. Those are going to be your direct acting bronchodilators. So they're going to help relax those muscles to keep the muscles from holding those airways down tight and provide a greater dilation of those airways. Again, the goal, as before, is to get the most out of the tissue that is functional that we can get. Optimize lung function. These patients are going to be getting corticosteroids in an effort to reduce some of that inflammatory process that's going on in the lungs. So we're going to definitely see these patients getting corticosteroids. We may add mucolytics to these patients or expectorants, drugs that help them either loosen up those secretions and or expel them. So we may put them on drugs that actually create a bit of a cough effect, but also in the interest of getting those secretions out, we want to loosen them. So that would be medication like guaifenesin is going to help loosen those secretions and make them more mobile, and they help them to get more benefit from the cough they do have. These patients may, if they're severe enough, be on supplemental oxygen. Oxygen saturation is not as much of an issue with these patients unless they're pretty profound CO2 retainers also. Oxygenation is, oxygen use is not such a big issue with these patients as it is with the emphysema patients. And as I said before, the therapy, the complexity of the therapy is going to depend on the severity of the symptoms. So, what factors make bronchitis patients more susceptible and vulnerable to infection? There's actually two, and we will revisit this in class, but there are two components here, and that is both mucus production. So there's a place, granted, mucus is supposed to trap potentially infectious inhaled matter. However, if we're not able to clear it enough, and there's plenty of mucus sitting there, it serves as a growth medium for bacteria. Again, the whole purpose of having it is to get that stuff out. And if you have trouble getting it out because there's so much produced, then you have a growth media for that bacteria. So you have a growth media, it's nice and warm, and there's lots of blood flow down there. Great place for bacteria to hang out and grow. The second is if patients are on corticosteroids, they're immune compromised or immune suppressed slightly, and that can potentiate infections and lead to precipitate pneumonias. Asthma has a different pathology yet from both emphysema and bronchitis. In asthma, you have hypertrophy of the smooth muscle tissue around the airways. Emphasis, smooth muscle tissue, not the mucoid glands, but the smooth muscle tissue around the airways. When that muscle tissue gets hypertrophied, as you can see in image B, that creates a narrowing of the airway. Image A is a normal airway. You can see this white space in the center, nice and open. You see the white space in the center here, looks like an hourglass. It's much more compromised than this image. But before, you see that result. But what I want to emphasize to you is notice this blue tissue here, which represents the smooth muscle around the airways. Look at the thickening of that smooth muscle and the connective tissues around it. So this is what I refer to as the hypertrophy of the muscle. That's what hypertrophy means, is increased muscle growth. And chronic inflammation refers to these connective areas here that are, this is depicting the inflammation surrounding the airways. So those two things, the tissue's got to go somewhere. And if you expand this tissue, it's going to collapse the airway. And that's the issue here. When I say reversible or potentially reversible, that is not to imply that any asthma could be potentially reversed. When I say reversible, what I'm commonly referring to is juveniles, people who are very young at the onset of their asthma, typically preteen. If you have a very young onset of asthma, there are situations in which, with good treatment early, and then also as they mature and move through adolescence and puberty, those growth changes as a result of puberty can cause a reversal in some asthmatic conditions. So commonly, allergy is the strongest predisposing factor. When I say allergy, I'm referring to an allergen out in the environment. One of the key components for management of asthma is understanding the individual understanding their triggers. What are the allergens or environmental conditions that trigger their airway? And commonly, it's going to be an allergen. The issue with asthma here, when you or I, if none of you have asthma, when you and I encounter an allergen that causes you to sneeze or to have an itchy nose and watery eyes, whatever the allergic response is, our body responds as a guard dog to help protect us. And so it sounds the alarm. It inflames the airways, makes them irritable so that so the cilia get active and we sneeze or we cough. This is a normal response. We move away from the area where whatever the exacerbating allergen is, and the situation resolves. With asthma, the immune response is like a hypervigilant guard dog. So this is a guard dog that is reacting at the slightest thing in the most extreme ways. This is what I mean by hypervigilant. This is like the guard dog that you have at home that instead of barking only when another dog is in the yard, if it sees a bird land in the yard that is just a bluebird or a blue jay or something like that, then it just loses its mind and begins barking and growling and trying to tear a doorknob off to get outside to attack this bird. That's what I mean by hypervigilant guard dog. In patients with asthma, their immune system responds in that way. Hypervigilant, very aggressive. This image gives you some of that breakdown about how that process happens. So, top left corner, you see the allergen, and these little triangles reflect the allergen and conceptually floating around in the environment. When the allergen moves and makes contact with whatever tissues it comes in contact with, whether it's skin, in this case, we're talking about airways, we have an interaction with IgE, immune globulin E, that's secreted from lymphoid tissue. When that immune globulin is activated, that signals mast cells. And this is a normal process. This is what goes on with us. But again, with the asthma patient, this gets overstimulated and overactivated. When that happens, you get a release of a combination of chemicals that mediate our immune and inflammatory responses: histamine, leukotrienes, chemotactic factors, and bradykinins. These enzymes produce what we refer to as our immune response in various ways based on what is triggering it. When that happens, you get a stimulation of those enzymes, cause a decrease in cyclic AMP, which causes an increase in contraction, in this case specifically of smooth muscle. So we have hypertrophied smooth muscle, and we have inflammation already in place. The cells around that airway are primed to have an immune response. That guard dog is just ready to attack. So when this allergen makes contact with IgE and release the mast cells to stimulate these mediators, you get this incredible release and clamp down of these smooth muscles that have hypertrophied and are very strong. and then collapse the airways. This is what produces the big airway compromise in patients with asthma. And I just want to call attention here. You see histamine. Histamine is a biological product. So antihistamines block the effect of histamine to create this. Leukotriene antagonists, again, act at this level. This is something that's going to come up when we talk about drugs in class. Now, for asthma, as with always, exposure, family history. So in this case, we're looking for family history. There's not necessarily an increased cause of asthma by smoking. However, smoking may cause an increase in the exacerbation of someone's asthma. So family history is definitely a component here, and not just limited to asthmatic history, but also inflammatory diseases, lupus, etc., other inflammatory diseases will be a part of that family history. Cough here may or may not be productive. And the cough commonly, if it is solely as a result of asthma, is a result of bronchospasms. So those airways getting that signal to contract those smooth muscles by that decrease in cyclic AMP causes a spasm of the airways, which creates the sensation of coughing. Obviously, the patient may have asthma, emphysema, and bronchitis. In that case, if they've got bronchitis, they may have a productive cough. There may also be an anxiety component here, so that's a good thing to investigate. Anxiety could be a result of the asthma or may be contributing to the asthma. So as you can imagine, if your airway becomes compromised and you feel like you're starving for air, having air hunger, which is a common complaint for asthmatics, then anxiety definitely is going to skyrocket. So anxiety management is critical for these patients because you have to think clearly as you begin. If you have an exacerbation of your asthma, you've got to think clearly about how you're going to manage it to mitigate this exacerbation. These patients will commonly have dyspnea. They feel like they're having to breathe their air through a sippy straw. If you can you can imagine breathing through a regular straw, but trying to breathe through a coffee straw. That's what these patients feel like. They may be diaphoretic and tachycardic, not necessarily because there's such a demand on their system, but because they're scared trying to breathe and they're having to work so hard to do it. Then also the classic symptom for asthmatics, as we mentioned before, the classic symptom for emphysema patients is hypercapnia. The classic symptom for bronchitis patients is a chronic productive cough. The classic symptom for asthmatic patients are wheezes. And wheezes can have a range of presentation from very minor wheezes that some patients have all the time to wheezes that are producing a condition called status asthmaticus, which is a severe and life-threatening presentation of their asthma, to actually the subsequent disappearance of wheezes because the airways have become so inflamed and contracted that they're not even moving enough air to produce a wheeze. That is a life-threatening manifestation of status asthmaticus. So things to watch out for there. Another tie-in to wheezes is stridor. Stridor differentiating from wheezes because stridor is referencing a limitation of airway in the large airways, specifically referring to the trachea and or the throat. So you have larger airways producing stridor, smaller airways producing wheezes. The asthmatic assessment is going to also be typified by a low peak flow. In other words, when they're trying to do a forced exhalation, the amount of air that the amount of flow that they can force out through a peak flow meter is going to be very low compared to normal. That's because those airways are constricted. Again, they're trying to blow air out through a little bitty straw. These patients may have hypercapnia. However, their biggest issue most commonly is hypoxemia because the airways are so constricted, they're not getting oxygen. So we're not concerned about putting oxygen on these people. We want to get oxygen on them. More importantly, we want to get their airways open. And that's going to be discussed more with the drugs we're going to talk about in class. So I'm going to break those out for you. But this slide shows you we're going to talk in class more about how the different drugs work strategically to create this process. What I want you to be familiar with here is this is the standard treatment for asthma based on the gold standard, the global initiative for obstructive lung disease. That's what GOLD stands for, not just gold as, like a currency. So this staging, step 1, step 2, step 3, step 4, step 5, is the staging for how we introduce medication and medication treatment for asthmatics and how we step it up based on their clinical presentation. We'll discuss this in class, but I want you to be familiar with this stepwise process. I want you to be familiar with what happens when they show up, as is indicated here, with intermittent asthma. What do we start with, and then what do we add next? So we start with a short-acting beta agonist, then we add a low-dose inhaled corticosteroid if we're having breakthrough, or if there's a reason not to introduce inhaled corticosteroids, then we can use cromulin, a leukotriene receptor antagonist, or theophylline, and you can see how we start adding drugs with each step as the symptoms exacerbate. This slide, or this image, it represents the same information. This is from Karch, your drug book, and it shows how with intermittent asthma, you basically have a short-acting beta agonist. Then when you have mild symptoms, you keep the short-acting beta agonist, but you may add inhaled corticosteroids or leukotriene receptor antagonist or sustained release theophylline. I want you to be familiar with this. It doesn't matter which one of these images you learn from, they both depict the same information. Personally, I think this stepwise graph is more easily understood. So with asthmatics, we're going to start with inhaled corticosteroids. Notice that's different from both bronchitis and emphysema. So compared to the other forms of COPD, we're starting differently. Remember the mantra, treat the problem, manage the symptoms. We're going to manage their symptoms. We're going to do our best to treat their hypoxemia and all of that, but we've got to treat the problem. And in this case, the problem is inflammation and hypertrophy. And you're not going to be treating that if you're not using inhaled corticosteroids. So we go to that sooner than we do with other conditions in the COPD family. We are using beta-2 receptor agonists, both short-acting and long-acting. That's where we start because they dilate those bronchioles. If that's not effective, then we're going to add the long-acting because we need more support in a more chronic way. Other things we may use here, antimuscarinics, leukotriene receptor antagonists, biologic therapies, methylxanthines. Again, the complexity of the treatment depends on the severity of the asthma. So nursing management here, medication education is fundamental, critical. I can't emphasize it, how important it is enough for these patients, because these patients can have multiple inhalers. They may look the same to John Doe, but they work differently. If you're inhaling your long-term beta agonist or long-acting beta agonist for an acute problem, it's not going to get better because those are long-acting drugs. If you're having an acute exacerbation, you've got to use that rapid-acting inhaler, and you've got to know the difference. This is why the management plan is so critical. You see it's got asterisks next to it. Management plan and education of the patient and family are so critical. So critical, in fact, that someone in the family that's going to be with the patient almost all the time needs to know. So this may involve not only mom and dad, but also siblings. So if you've got a middle child, say 10 or 11, 12, 15 years old, and you've got an older brother or sister that's 18, those other siblings need to know the difference between the rapid acting inhalers and the long acting inhalers, because the patient may be too confused and too scared to be able to differentiate those. One of the key parts of the management plan, in addition to knowing the medications, is being familiar with irritants and things that exacerbate the asthma. This may involve allergy testing, differentiating between gas-producing foods for this particular individual, may affect whether powerful odors such as perfumes or strong cleaning agents are able to even be in the house. All of these things can be active triggers to a patient's asthmatic conditions. So allergens can be critical. Gas-producing foods, the reason that's an issue is because if a patient ingests food that produces a lot of gastric distension, now you've got pressure from the gastrum pressing also up against the lung parenchyma. So as if they have an exacerbation after they've just eaten, 2 or 3 bratwursts, and that causes a great deal of indigestion for them, and then they happen to encounter one of their allergens or irritants, they could have an asthmatic attack that could become very severe because this gas in the stomach produces pressure in the gastrum, produces pressure on the lung parenchyma from the outside, which combined with the narrowed airways makes it almost feel impossible for them to breathe. So you could see where these things can work together in concert to create a problem. If they're smoking, this may mean smoking cessation for the family. If the family's not going to smoke, then they need to go outside, particularly if that's going to irritate someone's airway, because we're talking about the A in ABCs here. So I'm sorry it's going to be cold when you're standing outside smoking, but if you're going to keep doing that when your child has asthma, you're going to have to be cold while you smoke. That should just be a priority. So those kind of things have to be emphasized in this management plan. Also, as a general rule, these patients would do best to avoid crowds, because in crowds you can't control what irritants are around or on people, what powerful odors are in or around on people, or what infectious diseases people are carrying. So those can be key issues, particularly because, remember, the beginning treating the problem involves inhaled corticosteroids. So we're putting these patients' airways, we're exposing those airways to steroids on purpose that can make them susceptible to infection. Immunizations become critical. I haven't emphasized them before now, but again, for these patients, they're on immunocompromising drugs. Immunizations are critical. If you can avoid pneumonia, if you can avoid the flu, if you can avoid COVID-19, you're reducing and mitigating your risk for something exacerbating your asthma and causing a life-threatening event just from the flu. And it happens. I'm not making that up. Pulmonary rehabilitation, this may not necessarily be an inpatient arrangement. This here we're referring to rehabilitation such as breathing exercises. This could be done with an incentive spirometry device, regularly doing incentive spirometry exercises. There have been controlled peer-reviewed studies that indicate that exercises such as yoga and other and other forms of exercise that emphasize various breathing techniques actually improve peak flow in patients who have asthma. So when we're saying pulmonary rehabilitation, that's what we're referring to is breathing exercises that enhance lung capacity. And then again, as I've alluded to already, recognizing the signs and symptoms of an exacerbation. So educating patients about when symptoms are becoming worse, how to help them dial in to their early symptoms, what are indications of infections, what are triggers, all of those things. What does hypoxemia look like versus hypocapnia? Because these patients are more inclined toward hypoxemia. What does that look like compared to the other changes? So those keys are essential in the management plan for asthma. The next lectures will step into restrictive lung diseases, which have a very distinctive difference from obstructive lung diseases.